actually causing risk to pediatric patients in our community. I'm Pat Flynn. I'm a pediatric cardiologist at Avalon Pediatric Cardiology. I've been on the faculty at Weill Cornell for 40 years as of next week. And I started this practice about a year and a half ago, where, among other things, I actually have a lot more time to spend with patients who have the type of conditions that we're going to talk about. I'll be joined by Jamie Palaganas, who's a pediatric neurologist at Pediatric Neurology of NYC, and Ryan White, who's a PhD in physical therapy. And we will be talking about the spectrum of disorders that start with lightheadedness and then include fainting, and then that very elusive diagnosis of postural orthostatic tachycardia syndrome, or POTS, and the thought process behind why people are afflicted with these things and how we can help them. The lecture is being recorded, and our plan is to be, my other disclaimers, our plan is we want to be done with this will be very much a discussion between the three of us. We plan on being done with that around 12:45 to allow for 15 minutes of question and answer. But we are also, at the end, I will have all the information for the three of us, and we're always available to talk about these topics or anything else afterwards. The other disclaimer I have to give is that I am really, despite the fact that I'm a physician and I should be a scientist, I am one of the most superstitious people that I know. You'll notice the color combination of my slides today and the border that kind of conjures Madison Square Garden. If the Knicks win tonight, I will take some credit for that. And the problem with that is we will all have to reconvene on Friday for another webinar. If the Knicks lose tonight, I will blame myself or all of you, or I will probably just do what I usually do, which is blame the referees. I want to go ahead and get started. I don't know, Jamie and Ryan, if you'd like to say hello, and then we'll start by talking about a patient that we have actually all three seen together.
Sure, I'll take a quick moment. So I'm Jamie Palaganas. I'm a neurohospitalist by background, and then started a private practice a couple of years ago, 2.5, 3 years ago now, where, as Dr. Flynn was saying, we spend a lot more time with our patients. And one of the most rewarding parts of that is several of you know about our collaboration and our collaborative group that we have called Collaborative Pediatrics, of which Ryan is also part. And so we share some patients, and I will either see patients in Ryan's office or in Pat's office, and we sometimes can collaboratively take their history and do things in a much more coordinated way, which is really nice. And especially for patients like this, having some warm handoff between providers is super valuable, and helps the patient from feeling like they're just telling their story a million times and answering the same questions. So I hope this is helpful for everyone.
Yep, and as Pat and Jamie introduced, I'm Ryan White. I'm a graduate from Columbia here in the city. I got into private practice about 3 years ago, really looking to, and I'm kind of echoing both of the two of them, spend more time with my patients, especially patients with POTS, or POTS-like symptoms are definitely a population who need that kind of quality care. Rushing through, their physical therapy, regardless of how it looks, is not really a good formula. And I will kind of explain a little bit more of that later. But very, very blessed to work with Pat and Jamie here, and it's been a really fun journey just getting to collaborate with other professionals on these cases.
So we'll get started talking about a patient. I'll call her Amanda, although, as you know how these things go, her real name is anything but Amanda, who's a 20-year-old college student that I saw earlier this spring. She was referred for a history of chronic lightheadedness and episodes of syncope. She's had several year history of sporadic, what she considers to be and describes as bad days where she gets up with significant fatigue, dizziness, and brain fog. Brain fog is actually a term that is used and is, I think, very illustrative of one of the symptoms that people with POTS have, and will have that for hours to days to weeks at a time. She also has had a history going back to when she was a tween of having 1 or 2 episodes of fainting a year. Classic, what we consider to be vasovagal fainting, where she feels lightheaded, feels the need to sit down, If she sits down, she ends up slumping over. If she doesn't get to sit down, she will lose consciousness and fall on the floor. And she'll have brief loss of consciousness and recover spontaneously after that. As I always say, that the treatment of fainting is fainting. She also has a history of chronic headaches. She was diagnosed earlier in life with migraine. She's been recommended to take magnesium supplements. She's been recommended and prescribed triptans that she doesn't generally take. She has a history of polycystic ovarian syndrome and abdominal pain. She has loose joints, ligamentous laxity. This causes her to have difficulty with balance anyway, and also frequent sprains and strains. She's on Prozac for anxiety for 4 years. Her symptoms precede that, and Vyvanse was added about a year ago for ADHD during her senior year of high school. She says she can't get started in the morning without caffeine, usually drinks 2 caffeinated drinks a day, usually not more than that. She carries a water bottle around with her, doesn't really particularly dogmatically use it. She drinks alcohol on weekends, and she has noticed that moderate drinking on the weekend causes significant hangovers. The same amount of drinking that a roommate or somebody else might have leaves her a little bit more knocked down the next day. She came to see me because of a 6-week history of worsening symptoms. She had 3 episodes of syncope, of fainting in the previous month, which is the biggest cluster that she's ever had of those. Those are usually, several months apart. And she's been having 2 or 3 of those bad days every year, every week, where it takes her over an hour to get out of bed. She fights through it. She wakes up. She has a headache after getting up these days almost every day, even on the okay days, or the bad days, or the good days. She's been able to attend class, but on those bad days, she has brain fog and fatigue. She can't really take notes. And on those days, she doesn't have any energy for socializing. She can drag herself to class and back, and that's about it. She does have difficulty falling asleep, which has been worse since she's been away at school. It takes her more than an hour to fall asleep after she tries to go to bed. And she wakes up frequently during the night and has difficulty going to sleep. And as I said, she's got 2 or 3 bad days, a couple of okay days, and 1 to 2 or 3 good days a week. But she has been attending class consistently. But I would take a break right here to ask Jamie and Ryan, like, what are your thoughts just about that? And particularly, Jamie, when you hear this story as a neurologist, how worried are you about her? Versus how much do you think that an evaluation and management can help her out of this?
Yeah, so I think that's the excellent question is how worried, and honestly, not very worried. You could read that history, and I could put myself in that. I remember that I was that patient. So it's very easy to kind of normalize it from my perspective because these are symptoms that a lot of people, especially adolescent females, have to some degree. Not everybody to the same degree, and it can wax and wane over time. But normalizing it is actually an important thing, and realizing that sometimes we do go through this, and how to manage it is really important. And so based on that history, there are no big red flags. And often patients will talk about how there's no rhyme or reason to when these symptoms worsen. But as you really take the time that we do to dig into the details of life and different factors, there are clear patterns and clear triggers that do come up. Not 100% of the time, but very often. And there are very key red flag things that I look for, which we'll talk about a little bit more to make sure that I'm not super concerned. But I typically gather history by just letting them go, flight of thought, and see what details pop out. And then I ask some more questions to delve into some of those details to make sure we're not missing red flag symptoms. But overall, neurologically, while these sound very impactful to quality of life, they do not sound dangerous despite the severity and intensity of the symptoms they're facing. And so that's an important delineation, that it can be serious without it being dangerous. And how we manage that is it's not just a one size fits all solution. And that's where a lot of the detail comes into play.
If I may also add, I'm usually the last person to see the patient, which is great because I'm not necessarily worried so much about red flag because Pat and Jamie are working very hard to rule those out. But when I do my subjective interview with the patient before our treatment, sleep is one of the things that I ask a lot about. And it's very typical that these patients are either waking up uncomfortable, having difficulty going to sleep. And I try to give a lot of education on sleep posture. So trying where they're comfortable, if how I can make them more comfortable, positioning pillows, potentially even doing a few movements before bed to try and relax. And then a bigger one, honestly, is going to be something called sleep hygiene. It's a term that's getting thrown around a lot more recently, and I'm a big fan of it. And it's basically just, for the hour and a half before bed, what are you doing to prepare your brain to sleep? If you find that you're getting to bed and your brain is racing, I can make some assumptions of some things that you were doing before bed, i.e., cell phones, computer, TV, and basically getting patients into a better routine before bed, basically trying to signal to the brain like, hey, we're about to try and do this sleep thing, has pretty positive results.
And from a cardiac standpoint, I agree. When I hear a story like this, these complaints, these symptoms are very, very common and clearly more common than they were 30, 35 years ago when I started. I think there's a lot of factors in terms of the fact that we do kind of encourage and demand more activity out of our young people, which is good. I think that a lot more caffeine use at a lot younger age kind of provokes some of these things. From a cardiac standpoint, we have to kind of always start at the worst case scenario and go back to it. And particularly in the setting of the syncope, the differential diagnosis of syncope in the pediatric, adolescent, young adult age group includes all of the bad things that I put under the list of sudden cardiac death in the young, but with the caveat that everything about Amanda's description seems very, very unlikely for those. The fainting that we worry about in people who are at risk for those conditions is fainting with exertion or abrupt fainting without any prodrome or any warning. In this case, she really has the lightheadedness that precedes the fainting, which is really good. But I would be remiss if I didn't talk about sudden cardiac death in the young, and that's the main reason for people to have an evaluation for this type of situation. As I said, and as Jamie was saying, now I have the luxury of not just doing a brief evaluation and waving from the doorway and telling people your heart is normal, good luck with that. We really do have time to sit and describe to people what's happening to them so that they can understand how to make it last. But going back to sudden cardiac death, it happens. It happens about 2,000 times a year in the United States, when usually the great majority of those happen during vigorous activity. And these will be normal, healthy athletes, young athletes with no prior knowledge of any cardiac condition who have a cardiac arrest. Survival is better because we do have defibrillators around and hopefully people who know how to use them. But we do in this country, we do not really do anything in the way of screening for the risk. We did a whole webinar about a month and a half ago about this, so I'll just hit the highlights. Around the world, they do, I think, a much better job. And now that the World Cup is in the United States, we should take the advice of some of these countries. Italy, for about almost 40 years, has been demanding an EKG prior to young people participating in high-level sports at the level of an association or a federation. And they showed in the first decade of that the risk of sudden cardiac death, the reported risk of sudden cardiac death, dropped by 90% in Italian athletes. Now, in the modern era, they actually demand not only an EKG, an echocardiogram, and a stress test prior to participation, and they repeat those things every year or two if people remain in those endeavors. Many other countries at least demand an EKG for participation in high-level sports. And the International Olympic Committee, FIFA, and the International Cycling Organization require EKGs in people who are on a trajectory toward that and recommend echocardiograms. In the United States, we don't have any screening program. We have a couple of pediatric practices in New York who are offering screening EKGs in their office, and I applaud that. Florida is the first state in the United States starting with this coming school year, that anybody who is going to be playing a varsity high school sport, a high school sport, not at the varsity level, but at the school competitive level, will need to have an EKG before they participate. There we go. What are the causes of sudden cardiac death? These are the diagnoses that we deal with in pediatric cardiology that are the explanations for those 2,000 cases. The chief one being hypertrophic cardiomyopathy, which is abnormal thickening of the heart muscle. How do you diagnose that? Well, the American Academy of Pediatrics thinks that we should screen for that on physical exam. So when you go to the pediatrician or your adolescent medicine person, or you go to your internist and they have you squat down and then stand back up again and listen for a heart murmur, that's what that's for. The problem is it's not a very good sign. It's not very reliable, and nobody really does that on a screening exam. We can find hypertrophic cardiomyopathy. This is the main target of EKG screening programs. Most patients with hypertrophic cardiomyopathy, if they're at risk for anything, will have an abnormality on their EKG. Some will have a normal EKG, but an abnormal echocardiogram. But those, it's usually the other way around, especially in the adolescent years. Coronary artery anomalies and aortic aneurysms are also things. Coronary artery anomalies in the United States, and that's being born with a coronary artery coming from the wrong place. That's actually number 2 on the list in the American database. And the unfortunate part about that is it will, along with aortic aneurysms, those will escape screening on EKG and only need to be seen on echocardiogram. Most of the rest of the list are arrhythmias. And even if you're not having an arrhythmia during the 15 seconds that you're having your EKG, most of those conditions will leave a fingerprint behind. And so the EKG will suggest, will be diagnostic for Wolff-Parkinson-White syndrome or long QT syndrome, and will show up for arrhythmogenic cardiomyopathy and Brugada syndrome if you're looking carefully enough. And then the 2 that I added at the end, myocarditis and commotio cordis, they are on that list of things that happen to athletes. Those are frustrating in that you can't screen for them because they're acquired. Myocarditis is an inflammation of the heart muscle that happens after a viral illness. So a person could be screened today and 2 years from now develop myocarditis. That's why we will often tell athletes, if they've gotten over a viral illness and their symptoms are gone, but they're very fatigued, having chest pain, anything like that, this is probably not the time to go right back full bore into competition. And commotio cordis is what happened a couple of years ago in the NFL game. That's an abrupt trauma to the chest that causes a cardiac arrest, and obviously that cannot be screened for because that's basically a freak accident. But those are the things that nothing about Amanda's presentation makes me think that she's at high risk for any of these. Yet, again, doing this for several decades, many times I've found these conditions in people who were being worked up for that, and then we were grateful to have found them. Jamie, what do you think about the neurologic, what's in the neurologic differential diagnosis?
So it's always interesting to me how many patients sometimes come to neurology first, or they go to cardiology first. And in the inpatient setting, a lot of patients present with the first time passing out in the ED, and the ER will do an EKG, it'll be normal, and then they call us for could it be a seizure? And even if there are no red flag features about it, that is the most common question that people ask when somebody passes out. So that's not the most common thing. It is typically some sort of autonomic dysfunction, which we'll talk about the various degrees of that dysfunction more in a little bit. But seizures is the most common question that people ask us. Now, that requires a lot of very detailed history because it depends on the age of the child, and it depends on, a lot of different factors, how well they're able to kind of give you, do they have that lightheadedness? Were there any warning signs beforehand? But if they can give you a beautiful pre-syncopal history and then they pass out and then they wake up and they're back to themselves pretty quickly, that's great. One of my big pet peeves is when people say, oh, well, they had a post-ictal period. So post-ictal just meaning after any paroxysmal event, and they didn't bounce back to themselves right away. And my question always is, have you ever passed out? Because I've passed out and I wake up um, and I don't feel great. I still might feel super run down, shaky, exhausted, but I'm aware and I'm not truly confused. I might be confused as to why I'm on the floor. But then once I kind of regain my, wits about me, then realize, okay, this is what happens. And I know who I am, where I am, things of that nature. Postictal from a seizure is typically very different. But even more than that is if you have somebody who passes out and loses muscle tone, so often when people faint, we asked for details like, was it a Disney princess fall where it's very sort of slow and graceful to the ground, or did you fall really hard? But seizures that actually cause loss of muscle tone are very, very brief. If you stay without muscle tone, so you faint and you're floppy and you're out for a few seconds, a minute, and then come back to, that is very unlikely to be seizure, because seizure, if it does create a lack of muscle tone, it's usually for 1 to 2 seconds. And then there's stiffening. So where it gets more confusing is in convulsive syncope, which is you pass out, it kind of looks like seizure. It may look exactly like a generalized tonic-clonic seizure, which please don't use those terms. Just describe exactly what you're seeing. It's so much more helpful to the neurologist on the other end of the phone. But that can look a lot like seizure. There can be subtle differentiations of the type of movements, what the eyes are doing. Is it synchronous, asynchronous? That help me differentiate whether or not it was likely seizure. But convulsive syncope is just a consequence of the brain transiently not having enough oxygen. You get jerking, and then you wake up. So as I said before, this patient could be me. I had convulsive syncope. My dad was an ER doc. He would just look at me and be like, she's fine, and let me be. And then I would wake up and I'd be like, I did it again. And so convulsive syncope can look really frightening, but is fairly common in the grand scheme of things. The other big things that come up or questions that come up, migraine variants. Sometimes you can have vertiginous migraines or basilar migraines that can present with paroxysmal dizziness. Things that cause paroxysmal dizziness is another, or migraine variants that don't have headache can be sometimes thought of in there. Brain tumors on the list because anytime there's a neurologic symptom, everybody is worried about could there be a brain tumor. We have very good questioning and also exam techniques, as silly as a lot of the things we do on neuro testing may seem. They are extremely sensitive for us to figure out whether or not you likely have a mass lesion in your brain. So not something that I think of in passing out unless you have a whole backdrop of other symptoms. Highly unlikely, but certainly something we're always considering. Demyelination, autoimmune disorders, can they present with things like that? But they wouldn't have just these isolated loss of consciousness episodes or lightheadedness because it needs to localize somewhat. And this doesn't really localize to any specific part of the brain. While we're talking about the autonomic nervous system, that is not something I can look at on MRI or on CAT scan or on an EEG even. And then the last one on there is functional neurologic disorders, of which that can encompass any symptomatology you think of, and you can have true and true vasovagal syncope and have functional syncope, which is very similar in appearance, but there are subtle differentiations. And Dr. Flynn and I have shared patients with both of those conditions at the same time. And so there are subtle things that I look for in history and ways of kind of going about discussing with the patients that I can sometimes tease out which events are truly vasovagal, which events are functional, meaning that it is not the hardware, it is not the autonomic nervous system dysfunction that's happening. It's the brain's software having a glitch, and it creates the same symptoms and the same sort of events that happen from their vasovagal syncope. But basically, the brain is really good at picking up on habits and then making them ingrained, and they start to happen as a way to kind of warn the body, uh-oh, it seems like something risky could happen. I'm going to do that thing that I know how to do and make you pass out, just from a different mechanism. And so that requires a very different sort of treatment plan. But again, same time, you want to treat these patients in mind and body. And so when Ryan talks a little bit more about his treatment, a lot of what I do is, do they need an EEG? So a brainwave test. My test is not nearly as good as Dr. Flynn's for like screening. EEGs are, did you not sleep well last night? It might look kind of slow. That doesn't mean anything specific. If you find one blip of an abnormal brainwave, if the story doesn't really fit, I don't know what to do with that information. If it is concerning, then of course we have to get more studies and look from there. But the question is, do we even need an EEG? That's the main test. Once in a while, we'll get an MRI, depending on what the clinical presentation overall is. And then a lot of it really is just the devil's in the details of the history, and then talking about what is your autonomic nervous system, and how the interesting thing about it is exquisitely sensitive to stress, physical stress, psychological stress, and we have all experienced autonomic dysfunction in some way. So if you've ever had that cold and you feel run down, and 3 weeks later you feel fine, but you go up a flight of stairs and you're huffing and puffing, and you're like, that's weird. What is going on? That is acquired autonomic dysfunction from a minor stressor that happens before. Same thing can happen if you're lacking sleep or other things of that. So again, we all experience this to varying degrees. And that's where the functional symptoms kind of come into play, because sometimes if you're having symptoms of vasovagal syncope or presyncope, or just worried about passing out again, you actually kindle those circuits and they start to fire and fire and fire as a warning to say, I don't feel safe. So I'm going to make you not have energy and sit still, because that's somehow going to protect you. And so it's actually really, you can have all of these things happening at the same time, and it's very difficult to tease out, but it's important to put all of those differentials out there and then pragmatically kind of work your way through and explain to patients why you can have migraines and seizures and functional symptoms all at the same time.
And I think it's important because you raise a really good point there, that when we manage people, and we'll talk now about the autonomic things, but when we give them advice about managing them, it's not even just the physiologic things that are adjusted and change and make them less likely to pass out again. It's also kind of empowering them with the notion that those bad things that they were undoubtedly worried about when they came through the door. I mean, I see a lot. Anytime there's a public cardiac arrest. A couple years ago, when the guy for Netherlands had a cardiac arrest on the field during the Euro Cup, Bronny James, when he had a cardiac arrest, it puts, and whenever there's one in a local community, it puts it in people's mind. And then that fainting episode that they had in the past now carries a little bit more worry. And the more you're worried about it, exactly that, the more it's going to trigger happening the next time. So what are these things? We've talked about the autonomic spectrum of disorders, and I look at these things as not so much a continuum, because it's not like people who have orthostatic lightheadedness are going to become fainters or are going to become POTS victims, but they all kind of have a similar thread. And I've just run through them quickly. And then Jamie, one of the things I think is interesting, the first time we ever saw a patient together, it was very interesting to sit next to each other and describe the autonomic nervous system, because I've often said, I've often given the caveat before I do it, and said to people, just understand, this is the cardiologist explaining the brain. And you pretty much said something to the effect of, just understand, I'm the neurologist explaining the heart. And it's really the interplay between the two of them. So we're going to define orthostatic lightheadedness is that person that gets dizzy when they stand up and they don't lose consciousness usually. This often happens first thing in the morning, and they have to brace themselves. This is different than vertigo. If a person is actually having, the room is spinning, then they should probably be seeing Jamie, and they should probably not be seeing me or anybody else. Vasovagal syncope is when people lose consciousness, and typically they're usually standing for a few minutes, and then they feel lightheaded, they become pale, they get often nauseous, and then they lose consciousness. And when they become horizontal again, they come back too. So that's why I always say the treatment for fainting is fainting. And postural orthostatic tachycardia syndrome, or POTS, is very different. I usually describe it to people as, if you've ever had that orthostatic lightheadedness, or you've ever had that vasovagal syncope or near syncope, that feeling that you have before that happens, imagine if that's the way you feel. And so the Mayo Clinic definition is a little bit draconian, and it's really the inability to tolerate upright posture due to unrelenting lightheadedness, interfering with activities of daily living for a period of 3 months. Now, that doesn't mean that people meet that whole criteria and I don't, and they are not eligible for the management strategies. To me, when anybody has any of these situations, most of the non-medical things will be helpful for all of them. There's another thing about postural orthostatic tachycardia syndrome, an observation made by Phil Fisher at the Mayo Clinic about 15 years ago, that a patient with POTS will increase their heart rate by 35 beats per minute within 10 minutes of standing, 40 beats per minute if you're an adolescent. And this is an observation that is true. All POTS patients will do this, but again, the warning is so will a lot of other people. So if a person is healthy and doesn't have those symptoms, or maybe they have orthostatic lightheadedness, but their heart rate increases by 35 or 40 when they stand up, that doesn't get them membership in the POTS club. And it's really not a club that you want to be a part of. So those are, that's the thing. I've talked to Phil Fisher about this, and he has said he wish he could take that back because that has happened to too many people. And I said it's kind of like fever and malaria. Everybody with malaria has fever, but most people who have fever don't have malaria. So these are a continuum, or at least related to the same inability with the autonomic nervous system to really manage one of the important things, which is distribution of blood flow to all of the organs simultaneously, and strategizing the brain and the heart as first. Jamie, how do you describe it to people?
POTS?
Or the autonomic
nervous system. So I talk about how it's the heart talking to the brain and vice versa. And so it's the communication of the two, and it's kind of the software, not the hardware. And there's a lot of different factors on that. Like I said, it's exquisitely sensitive to stress, any kind of stress. And keep in mind, stress comes in good and bad flavors. Going on vacation is still a stress. Changes to your sleep, changes to your diet, changes to your exercise level, climate, travel, all of these things factor in. So very common time to see increase in symptoms like this if you are somebody who's prone to that. In terms of the autonomic nervous system being more than just your heart rate and blood pressure. So I will also ask patients about their temperature tolerance. Are they the person who runs cold? Or are they the person who sweats dramatically when they work out? Or they don't sweat at all when they work out? And those different things are actually very important. Also screening for some of the mobility things, and a lot of why I invoke Ryan, because either they are too tight, so they're put together too tightly, I am put together too tightly, or they're put together too loosely. And both of those create problems and can create constriction, because you can be tight in certain places and loose in others. And that combination creates impingement on different vessels, on different nerves, and that can predispose you to things. So actually learning how to hold yourself, carry yourself, move yourself, and that's what we'll let Ryan talk about in a minute, is so important for the management of these patients, not just in your hypermobility spectrum disorder patients, but also in your patients that are really stiff or feel really stiff or tight, because there is almost always some component of that that's hardware based. And I think that's also, I often talk with Ryan about a lot of these patients, because I will discuss with them, also the comorbidities of ADHD, anxiety, stress. They'll tell me, oh, they're not stressed. I'm like, you're a teenager, you're stressed. It's just part of life. We're all stressed. We can't deny that is part of our existence. And then knowing the impact of that on your body. I am a very strong proponent of CBT for patients who have these symptoms, even if they've not had the progression to where they feel these symptoms every single day. But if they are very worried about the next time that they pass out, CBT is very important to keep down that brain trying to overprotect you and create these symptoms more, because that is part of the link in there. Is, again, your brain likes to create habits. And I always tell my patients, your brain is smart, but it's also really dumb. And a lot of times it tries to protect you by doing things like tightening you up because your joints are unstable. And therefore you create all of these impingements, and then you have pain, you have headaches, you have syncope, you have all of these other things that kind of factor in. And it downregulates your energy, it worsens your sleep, all of these things, because the more fatigued you are, the less likely you are to get up and do the things that make you feel even worse, but simultaneously making you feel worse at the same time. So your brain is trying to protect you, but it does it poorly. And your vagus nerve and your autonomic nervous system are very involved in all of that. So a lot of patients also will have irritable bowel syndrome. We have that on another slide too, just all these other comorbid things. When you link them together, what puts them all together is dysfunction of the autonomic nervous system, which is both your fight and flight and your rest and digest. So in this day and age, most of us live with our fight and flight response activated way too much, and our rest and digest does not work nearly as well. So if those are out of sync, and this sounds very Eastern medicine concept like, but because it's true, those need to be working together and equally. And if you are always hyper vigilant or super active and on the go, often those patients tend to run hot. They have a hard time sleeping unless the room is super cold. They sweat a lot, sometimes with exercise, sometimes just hanging out. They tend to be, a lot of them are, straight A students and in multi-sport athletes, and they're just kind of always in this hyperdrive state. And again, why I probably relate to them so well. And I'm like, oh yeah, I did all these things. The other challenge though, that remember from a neurologic perspective is their brain is not mature yet. So they think they know everything. They think they're doing all the things you're telling them to do, or they will just say, well, I'm just not going to do that. I don't want to do that. And that is coming from literally an immaturity of the brain. It is not their fault. We can all think back to when we were a teenager, 20s, early 20s, and then think back now and you're like, oh, I thought I knew everything. And only now do I realize how concrete and how poor my abstraction was and how poorly I was able to actually incorporate things that actually do make a big difference in my quality of life. So those are important caveats too, is what is your developmental age of the patient and how are they perceiving what's going on? What is being voiced to them by their teachers, their parents, their coaches, and other doctors, and demystifying some of this stuff, because the other problem that happens is a lot of times they won't see Pat, they'll see someone else and they'll say, oh, your heart's okay, so it's not me. And then they see a neurologist and the neurologist says, it's not a seizure, so it's not me. And then they just feel lost and they're floundering because nobody's actually put it together. And that's because it's not really owned by only one of us. It needs to be owned by somebody, and it's just who's comfortable actually managing that.
Yeah, and the way I like to describe it to people in terms of the autonomic nervous system is I start by saying, it's controlling the things that we can't control by our own volition. So the example I give is if I turn off the light, nobody can say, oh, I have great willpower, my pupils are not going to get bigger. Less light's going to hit the back of your eyes are going to send a message to your brain's going to activate the autonomic nervous system, which is going to send neurotransmitters out to your eyes to open your pupils. And then when the light comes on again, the autonomic nervous system is going to do the other thing that it does, which is reverse the thing that it did before. So now more light's going to hit the back of your eyes. The eyes are going to send a message to the brain. Neurotransmitters are going to go and tighten the pupils again. And we have no control over that. How it works for the cardiovascular system is that the easiest job for the cardiovascular system is when a person is lying flat. All of the blood in the body can make its way back to the heart without going against gravity, and the heart can pump blood to the brain without pumping against gravity. So that's why people's heart rate is always slower when they're lying down than when they're standing up. When we stand up, the blood starts to pool in our legs, and as much as 40% of the cardiac output gets lost by the decreased flow coming back to the heart. So what happens? The heart notices that it's empty. It sends a message to the brain, activates the autonomic nervous system. The autonomic nervous system sends out neurotransmitters, and they tell the heart to beat faster, which is why our heart rate increases when we stand up, to beat harder. It tells the veins to tighten up and start pushing that blood back to the heart. But the most important thing that it does is it tells the arteries in the body to either tighten up or loosen up, depending on where the blood needs to go. Right now, we've got 40% less blood to pump. We've got to still get blood to here and to here. So the arteries to the brain should loosen up a little bit so that more blood tends to the brain. And this is the time where we don't need to be pumping so much blood to the intestines or to the skin or anything like that. And if we do that fine, then we don't get dizzy. But if we're not perfect at that, either we get lightheaded when we stand up, or the second part of the autonomic nervous system, meaning that a few minutes after we've stood, the heart acknowledges that everything has been done appropriately, sends a message to the brain, the opposite neurotransmitters come and tell the heart to slow back down again. If we don't do that correctly, the first way we have orthostatic lightheadedness. If we don't do it correctly, the second way we have fainting. And those are the reasons for that. And that's why when a person faints or they're about to faint, they get pale and they get cold and clammy. It's because the body is appropriately squeezing blood out of the skin and trying to shove it back into the central part of the cardiovascular system, so there's more to go to the brain. It's why people feel nauseous when they're about to faint, because we're squeezing all the blood out of the stomach and intestines. And it's why very frequently people wake up after fainting, come to after fainting, and they have a headache. They have a headache because the body has tried to correct by sending more blood to the brain, and all that blood in the brain hurts. So these things, and when you explain that to people, they understand their symptoms so much better, and they have a little bit more ownership of it. And so how do we manage it? And these management strategies on this page, the lifestyle factors, these are good for anybody with any of the above, because they're pretty much good for anybody anyway. We need people to increase fluid intake. I tell people they should be drinking 3 liters a day, a liter before they go to work or school in the morning, a liter at lunchtime, a liter when they get out. That's the target. They need to increase the electrolytes in that. It's salt. Why is it that doctors are standing on pedestals telling society you eat too much salt? Because salt causes high blood pressure. These people are fainting because their blood pressure is sagging. So you need the salt in there to hold the fluid in your bloodstream. And that's why when I was a kid, all you had was water and salt tablets. That's why the scientists at University of Florida created Gatorade. And nowadays we have a lot more options in terms of the electrolyte supplements that can be put into drinks. Avoiding caffeine and alcohol. They're both diuretics. The more of either a person drinks, the less hydrated they are. And caffeine is worse because it's a stimulant. It's always turning on that first part of the autonomic nervous system, which is always making the parasympathetic work harder. Really important: stretching, strengthening, stability training, and exercise. We tell the rule for POTS patients is 30 to 40 minutes of exercise 4 or 5 times a week. And those people will look at you and say, I can't even get up off of the floor. Well, then you have to exercise on the floor. I've had people say, it takes me 40 minutes to walk the mailbox and back, then walk to the mailbox and back. What we're trying, that's not just for health, that's for retraining the autonomic nervous system. This is putting the autonomic nervous system in a situation where it has to appropriately increase the heart rate and the blood pressure, and then appropriately slow it down. So we have to give it practice. Compression garments are helpful, although especially in the summer, nobody's wearing compression stockings out in public. But I have a lot of people that have orthostatic lightheadedness in the morning, and they do well if they wear them at night. Sleep is really, really important. People who are not having normal sleep habits, and there's a subsegment of POTS patients who that's really one of their main problems is sleep disorder, and understanding symptoms come and go, and avoiding injury when you fall. These are not the people who should get up in the morning while they're still lightheaded, go run into a hot shower. Because what happens, and I explain this to people, what happens when you're hot? Well, think about when you have a fever, your face gets flushed. You go into a hot shower, your body temperature increases. The only way we can get the heat out of our body is to send it to our skin. And if we send more blood to our skin, we've stolen it away from inside. That's why people faint in the bathroom. It's the worst place to faint because everything in there is really hard. These are some of the things that are beyond that can be helpful. And I'll go through them quickly because most people with the first 2 conditions don't need these. But some people with really recurrent syncope that's affecting their lifestyle, and a lot of POTS patients will, and we could do whole webinars on each of these, and I'm going to kick it very quickly to Ryan to talk about this. Cognitive behavioral therapy, very important for people who are really have their lives affected by this, especially with POTS patients. Physical therapy, as I said, I'm going to kick that to Ryan. Other organ system specific treatments or prescriptions, and I'll have a quick slide that shows those. Considering withdrawal of medications that may be exacerbating. Our patient that I noted, remember, is on an SSRI and a stimulant medication. if you ever look those up, they're not supposed to be given together because of serotonin syndrome. She doesn't have serotonin syndrome, but you have to be careful. Most patients with any of these things, if those meds are helping them, I don't take them off. But it might not be a bad idea for her to come off of the Vyvanse in the summer and see if these symptoms get better. And then these are the medications. Florinef or fludrocortisone, we don't give as much anymore because all it does is retain salt, and now we have better salt supplements. Beta blockers, midodrine, ivabradine. Beta blockers really are the mainstay for both frequent syncope and for patients with POTS because it kind of affects that abrupt increase in heart rate that triggers the decrease in heart rate 10 minutes later in the syncope patients and really helps the POTS patients the most. And these are, I always say it takes a village. These are some of the other people that might be helpful because these are the comorbid diagnoses that a POTS patient might have. And these are the people who might be able to help them. We're trying to pull together a kind of a cohort of people that have expertise in POTS patients and that we can hand them over to for these things, particularly physical therapy and sleep medicine. I'm going to kick it over to because in the syncope patient and the POTS patients, we think that physical activity, exercise, and physical therapy are important. I'm going to give Ryan a couple of minutes to talk about why that's important and what can be done.
All right. Thank you, Pat. I'll try to be quick with this because I want to be respectful of everybody's time. Yeah, with physical therapy, especially in POTS patients, even though this does apply to most patients, the goal is to promote quality movement. And that does not mean, I want to give you a bunch of exercises to do at home alone. It's really how you're trying to accomplish those. So every patient's getting screened for their spinal mobility. I want to see how well their lumbar, thoracic, cervical spine move, not just right as a unit. So if we're testing the trunk range of motion, I'm not looking to see how far your shoulders go. I'm looking to see how much your lumbar spine moves, your thoracic spine moves, and your cervical spine moves, segment by segment there. I'm looking at your diaphragm and your breathing patterns. I want to make sure that those are not anything that I'm concerned about. If we have a stiff thoracic spine, that's going to be likely lead to a stiff rib cage, which will be affecting the diaphragm and how you're breathing. And Pat just spoke in length about how important breathing is with all of this. And then integrated strength. I have many things that I review with my patients, but I'm looking at primarily things like squats, planking, something called a suitcase carry, where you have a weight on one side, just how your body is responding well to different loads. Because if it is unstable, that's likely going to lead to tightness. Even in hypermobile people, they can be tight. Tight does not always mean short. You can have a muscle that is as a perfect length, but is tight and therefore dysfunctional because it can't contract and relax appropriately. Next slide for me, Pat.
Oh, wait a minute. Oh, I skipped one. There we go.
Yes, and as I was yeah, that is correct. As I was just talking about a second ago, there are really like three primary priorities that I'm looking for, and that's going to be thoracic spine mobility and how that relates to the rib cage. Rib cage houses the lungs and the heart. And my philosophy is basically if any structure is not moving correctly, there's going to be a degree of dysfunction to it. And better mobility in our rib cage is going to support better breathing mechanics, blood flow, and posture. Cervical stability, building strength and control in the neck helps essentially support the brain. And if our neck is unstable, that's going to put too much stress down below. So everybody's seen, whether it's an adult or a kid, with this forward head posture, right? That is going to put so much strain on the upper thoracic spine. That strain is going to lead to tightness. That tightness is going to lead to immobility, and then it's going to cascade from there. And then core integration. I had mentioned some exercises that I use for screening earlier. I'm trying to tie it all together to bring stability. Once something is stable, then it will feel much more comfortable being mobile. Next slide for me, Pat. Some simple tips. Walking. Everybody knows that a walk is good for you. It's obviously great for cardiovascular health, but a fun fact is when you walk, we are hopefully pushing well through our feet. And that is going to be using our calves. Actually, Pat had mentioned this before. That is going to help pump blood. There's a muscle called our soleus in our calves is specifically designed to help get that blood back up to the heart. So getting out and walking, even if they're not feeling like it, even if it's a 30-minute walk to the mailbox, right, is absolutely helpful. Box breathing. I almost think about this as exercise for the rib cage. You're doing 4 seconds inhale, 4 seconds hold, 4-second exhale, 4-second hold as well. We're just trying to get the diaphragm moving, the rib cage moving, and then exercise and play. Obviously, if your kid's in sports, that's great exercise. If they're not in sports, there's still plenty of ways to move. And that is going to be very important for these kids as they move forward.
And just to tag team on that, so I'm also a personal trainer and a yoga teacher. I can swear by Ryan's techniques for working on these things because I've always been very interested in how restricted my breathing is, and he's been really helpful for me to actually feel like I can breathe better, which is actually very impactful to all the things that we are talking about. But in my backdrop of screening them, I want to get them back to the highest level of activity as fast as possible, as safe as possible. A lot of patients try to take too big a jump and they don't do the gradual reintegration. And so between working with a PT and then I don't necessarily train them myself, but I might send them to people that I know who are really good about structuring workouts or talking to a sports specific trainer about different things to get them back to their level of activity in a proper graded fashion. Because if you set yourself up for failure by making too big a jump, you feel worse and then you feel like nobody's helping you. And that just makes this cycle even more ingrained. So saving time or putting time in early to benefit you long-term is much more beneficial than trying to rush the course of getting you back there. Many of these patients get to us because symptoms have worsened over weeks, months, and years. We can't roll that clock back overnight. And it takes time and a collaborative effort. And all of these different ways that we kind of approach it, that we each take different parts, and the CBT also being important. So often I'll segue over to Ryan to talk about the physical ways that impacts your autonomic nervous system. And then with continued messaging about that importance of the autonomic nervous system, sometimes we can get more buy-in from the patients to engage in CBT or just some of the breathing techniques. And then we can get them into CBT, which helps provide more long-term stability.
And I would also echo that what we're both saying, which is I would say over the course of a long career, the first half of my career in pediatric cardiology was about kind of almost the attitude of it was finding those people that have dangerous things and hurry up and get them off the field. Now, really, we, like everybody else, need to be the people who are fostering the idea that we need to get our children, our adolescents, our young adults onto the field, into the pool, onto the dance floor, into those activities that are going to make them healthy adults and make them happy. And even people that have the diagnosis that I talked about before, those are no longer a permanent restriction from activity. Bronny James wouldn't be playing in the NBA. That guy from Netherlands wouldn't be playing in the World Cup. Damar Hamlin wouldn't still be playing for the Bills if we didn't now realize that we can get people safely back onto the field and onto the court. Just briefly, I'll just tell you, and then I want to open it up for questions. We've run a little bit over, but we can stay if anybody hasn't. You can always reach out to us at the thing. Our patient, the cardiac workup was normal. Rhythm monitoring did show a brisk heart rate response. We did all those non-prescription therapies. She saw Jamie for management of the headaches. She had a referral to sleep medicine and has had greatly improved sleep performance. We have a sleep medicine specialist, Saima Tahir, that is here in the city, who's really got expertise in this. Physical therapy with Ryan, and she hasn't had any more episodes of syncope, but she will. But now she's having 1 or 2 bad days a week, 1 or 2 okay days, and the rest of them are good days. And the last thing that she said to me was, "I feel like any other college student now." So this is our contact information. I want to open it up for any questions, but feel free at any time to reach out to any or all of us about any information. But what did I just do there? Oh, there.
Extended your slideshow. You're good.
Sorry. Let me go back.
Feel free to put any questions in the chat or just unmute yourselves. We're happy to take any questions.
I, for some reason, can't see the chat. So, Jamie, feel free to monitor that. Oh, here we go. I've lost the audience on the chat. Yes,
no questions? Oh, there we go. Put the slide up again, showing Amanda's symptoms, please. And this was recorded. And so if you registered for it You can be, if you missed part of it or we're doing other things while there, you can always go back. The slides are kept quite brief, so if there are questions, please feel free to reach out.
Just going back to this, I would also say this line here is really important. When I can really convince people, and I'm the pot calling the kettle black. I'm a caffeine drinker, but when we can explain to people whose life and lifestyle is being affected, sometimes getting the caffeine out of their life is really, very helpful, and really getting them to really target that 3 liters a day with electrolyte supplements is really always number 1, 2, 3, and 4 for most people.
A lot of these patients will have, oh, someone joining us from the UK. Thank you. A lot of patients will tell us how great they are at hydrating. Never trust them. Make sure that they are using a water bottle that they can actually tell you how much. Stopping at the water fountain is not a considerable amount of water. And if they are an athlete, again, how much do you sweat? Like some people sweat way more than others. That is a very important factor. It's also very different if you are a rock climber versus a aggressive soccer player versus a weightlifter. All of these things matter. And so I because I'm a fitness nerd, I go into a lot of depth about what is your sport, how active are you, and then specifics about your fluids, about how much salt I think you should try, and we play around with it until we find the right combination. And or a lot of them eat these crazy healthy diets and don't add any salt, and so they are confused by it. And that was me as a teenager. We had no salt because my dad had hypertension, and so if only someone had told me back then to eat some salt, I probably wouldn't have woken up to my mom shrieking at me many times for having passed out. So, it's made a really big difference. And I have a lot of patients who just taking elements, their headaches are better, their dizziness is better. It's just with better knowledge about those things. So I think in the caffeine, just, if you're going to try to get them off of it or they're getting off a stimulant, don't rip it out cold turkey, especially for somebody who is, if they drink caffeine every single day. If you are a caffeine drinker, if you don't drink it, you probably are going to get a headache, and that can create its own problems. And from a neurologic perspective, migraines, concussion, dizziness, TBI, all sorts of things, even encephalitis, other sorts of neurologic symptoms that you get prolonged symptoms for, the recovery is very much the same things that we're talking about here. As Pat said in the very beginning, it's about linking all of these interventions are actually things that are good for all of us. And so I often make it a family discussion of like, what are the things you're doing well? What are you not? And it's okay to be that kid who's not the athlete, but there is something we can find that is going to be exercise or movement that promotes better health. You do not have to become a varsity athlete, but we want you to be moving. And that is important. And meeting them where they're at. So CHOP has a protocol for POTS, but a lot of our patients don't fit that specific protocol. So I will riff on that and give them recommendations and guide them up with small achievable goals. If they do not sweat, is the care different? They probably do. If they don't sweat, that's a different sort of workup in terms of why. Maybe you're on a medication like Topamax or zonisamide that stops you from sweating. And then we'll talk about maybe needing to switch that. It's not so much the not sweating though, because that's probably more effort-based. It's really for those who are profuse sweaters or who run really hot. Your insensible losses are just higher than you realize.
And there are people that like to kind of test the patients by following the specific gravity, which I think probably is a little bit of overkill, and it makes it seem a little bit more medical than it needs to be. I think the best way is to tell people to drink so much and look at the color of their urine. If their urine is as close to clear as possible, they're drinking enough. And if it isn't, then they need to drink more.
But if they're not putting any salt in, they're just peeing out the water,
Right.
and so it's not
Exactly.
actually working for them. One other question, are there particular age groups that you see these symptoms emerge? Some symptoms present at different ages. So my quick answer for that is adolescent females are notorious for all of these symptoms, whether it's growth spurt, metabolic changes, hormonal changes. Adolescent females are notorious for it. So I always ask for, did you go through a recent growth spurt? Did you start your period? What's like all of those different factors. Obviously, it does happen in males too, but I would say highest proportion is adolescent females around the time of menses or around the time where they're going through their growth spurt and early puberty. You might see it. And a lot of these patients may have a single episode of fainting, a couple like I think here, in years past, and then later on start to present with some of these more persistent symptoms. But it can really present at any age. It's just, I would say, it's the tweens to teenage years where you really start to see it come up. And I think that's also in part because they're more aware and more in tune and they have more demands on their day, and they put more demands on themselves. And so it starts to become more apparent.
An interesting thing about it is that for fainters, and I think also for POTS patients, when they're adolescent and young adult female, when they're either seeing a cyclical fainting or they see a pattern of POTS where it gets worse over, predictably within a month, it tends to be more around the time of ovulation than around the time of menses. And it's not as obvious that way. There are actually some patients who need to be, who will benefit from management of their menstrual cycle to break the POTS grip. And it's interesting because it makes sense, during a menstrual period. It's not like somebody loses so much blood that they should be getting dizzy. It's something hormonal around ovulation.
It's the stress of it causing your autonomic dysfunction to worsen. So if you're getting physical pain and other things like that, it's a complicated interplay of all these things. The software just gets glitchy. And the other thing is the software feels like it doesn't mature. The heart-brain response does not mature as well or as quickly as it needs to, especially in adolescents and adolescent females in particular.
Well, I want to thank everybody for joining us and taking some time out of your Wednesday afternoon to be with us. Hopefully, if you have any questions, certainly reach out to us. All of our information was on the slides and will be available it was available in the chat. Keep an eye out for other type of presentations and let us know what kind of things might be helpful. And we will put that up through Dr. Loop. And remember, when you're looking for a pediatric provider, look for Collaborative Pediatrics, because we're trying to find people who will have a response time and a commitment, to things that are slightly outside of the box that need to be fit in one half an hour visit. These are 2-hour visits for me. And I'm grateful to have that amount of time to spend with the Syncope patient, the POTS patients, and really everybody else as well. So unless there's any other comments, I want to thank you and hope we see you again next time.
Thank you.
And go next.
Thanks, guys.
Thank you.